Welcome to The Code Trade, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
First up, we have Zoe Dittmar, a PGY2 emergency medicine pharmacy resident from the University of Iowa, who will be presenting ketamine or etomidate for tracheal intubation of critically ill adults.
Awesome. All right. Thank you, Maddie. So we'll go ahead and get started. So my objectives for this presentation are first and foremost to recall the mechanism of ketamine and etomidate and the doses that we use in RSI, and then to summarize previous literature evaluating the choice of induction on patient outcomes, and then lastly to evaluate a recently published article on the use of ketamine compared to etomidate for intubation of critically ill adults. And so starting off with a little bit of background about rapid sequence intubation or RSI, there's a variety of reasons of why we would intubate a patient. First and foremost, or a pretty common one being respiratory failure. So somebody not oxygenating well compared to other invasive means of ventilation. Also, if a patient's having neurologic impairment, whether that's due to trauma or sepsis, and we need to gain control of the airway. Also, any cardiovascular instability or airway obstruction. And then lastly, if there's an emergent procedure or imaging that's necessary, we may choose to intubate a patient. And so our goals are to facilitate successful first pass intubation, prevent aspiration, and then also have as minimal effects on hemodynamics that we can. And so kind of a pre-intubation checklist that you may hear providers talking about are the 7 Ps of RSI. So you have preparation, making sure that you have everything in the room that you want, whether that's supplies, medication, personnel. Pre-oxygenation, so making sure that we optimize our oxygen saturations prior to placing the tube. And then we used to have one of the steps was called pre-treatment, where we formally administered some medications prior to going through the process of RSI, which has fallen out of favor. And then paralysis with induction, positioning, placement with proof, so getting like your chest x-ray, making sure you hear bilateral breath sounds, and then lastly, post-intubation management. And so like I have bolded there on the slide, biggest interventions that pharmacists can play a role in are going to be induction, paralysis, and then post-intubation sedation. And so when we think about an ideal medication for RSI, specifically when we think about induction and paralysis, we want a medication that's quick on, quick off, has negligible effects on hemodynamics, minimal side effects, and then also we want our induction agents to provide some pain relief, anxiolysis, and amnestic effects if possible. And so a brief overview of some induction agents. So again, this is producing a state of general anesthesia. We want something that is quick and short acting, but provides an appropriate deep sedation level. And a reminder that we always want induction to precede paralysis due to the risk of inadequate sedation or awareness with paralysis. And so got what I like to think of as our big 3 agents, especially in terms of the emergency department on the slide. And so reviewing some of those, etomidate, the mechanism being a sedative hypnotic that potentiates GABA-A, typically dosed at 0.3 milligrams per kilogram. And again, having that quick onset of less than a minute and then lasting just about 5 to 10. So most common side effects that we think of with etomidate are going to be myoclonus. And this is of note, not actual clinical seizures, more of just that muscle jerking that we may see, fairly rare. And then also acute adrenal suppression, which we will get into when we get into the article for today. And then ketamine being an NMDA receptor antagonist dosed on a range of 1 to 2 milligrams per kilogram. Again, having that onset of less than a minute and duration, again, that 5 to 15 minutes. And then adverse effects of ketamine can be kind of all over the board. Most commonly seen tachycardia, hypertension, hypersalivation, emesis, and potentially emergence reactions. And then lastly, propofol, a general anesthetic that causes CNS depression through GABA-A. Also being dosed on that range of 1 to 1.5 or 1 to 2 mg per kg. Also, as you can see, quick on and a quick off, and most common adverse effect that we worry about with this one is profound hypotension with the large doses that are required for intubation. And then just briefly about paralysis again, using neuromuscular blockers to paralyze our skeletal muscle by blocking impulse transmission at the neuromuscular junction. And so again, facilitating those ideal conditions to be able to place that tube while also minimizing risk for aspiration. And so remembering that our paralytics do not possess any sedation, analgesic, or amnestic properties. And so our big two agents, especially in the emergency department, are going to be succinylcholine and rocuronium. Succinylcholine being at a dose of 1.5 milligrams per kilogram, again, having that quickest onset and also shortest duration of all of our paralytics for RSI. And then a lot of our most prominent side effects being malignant hyperthermia and hyperkalemia. And then rocuronium being at a dose of at least 1 up to 1.2 milligrams per kilogram. Again, a fairly short onset when dosed at that higher range of 60 seconds, and then duration historically being noted as 45 to 60 minutes, but I think a lot of us anecdotally would tell you that we see it a lot longer, and then not any adverse effects that we worry about with rocuronium. For the purpose of this presentation, we're going to leave it at that. I could do a whole grand rounds about the difference between these two drugs, and I actually did. So if you want to talk to me about that. And so then jumping into our induction agent controversies, a little bit of background about the available literature we have that describes etomidate and the effects of adrenal suppression on patient outcomes. So a couple older studies, starting out with a couple from the 80s, one being a case report of just 5 patients that they did notice marked adrenal cortical suppression following receipt of etomidate. However, one of those being a continuous 20-hour infusion that we do not do anymore. And then 4 of those patients being surgical patients that had received induction and supplemental doses. They did see adrenal suppression lasting up to 4 hours after their procedure. And then next, again, a small sample of patients, but it was a randomized control trial where they looked at receipt of etomidate and then changes in like their plasma hormones and enzymes. So they found an increase in ACTH that was not statistically significant for those that received etomidate versus those that did not. However, they did find a statistically significant decrease in plasma cortisol, cortisone, corticosteroid, and aldosterone. But they did conclude that there was little clinical relevance of this effect. And then next, a study from 2008, an observational cohort study of 40 patients, again, finding that they did see adrenal insufficiency noted at 12 hours following a dose of etomidate, but that they found it was reversible or the effect was gone following or 48 hours after administration. And then in 2009, was after the Corticus trial was published, and so this was a subgroup analysis of patients with septic shock that received etomidate, and they did find a higher 28-day mortality in that group. And then similarly, a study from 2012, again, a pretty large systematic review that they found higher mortality in those receiving etomidate and just an increased likelihood of developing adrenal insufficiency. And then lastly, another systematic review out of 2013 that found an association between single dose etomidate and increased mortality. But of note, this systematic review in particular, and most of our data is driven largely by observational studies. And then moving on to ketamine, the other focus of this journal club today, and previous literature about its effects on hemodynamics. So we have an older cohort observational study of 12 patients, and these were critically ill patients that were found to have decreases in cardiac and pulmonary performance after receiving ketamine. And then another randomized control trial of 25 patients that, again, ketamine was shown to exhibit negative cardiovascular effects in patients with catecholamine-dependent heart failure. And then an observational study from 2016 that looked at 2 groups of patients, those that they defined as high shock index and low shock index. And so remembering that shock index is defined as the ratio of a patient's heart rate to their systolic blood pressure. And so a high shock index is like your 0.9 to 1 of that ratio, and that has been found to be associated with increased risks of adverse outcomes and higher mortality. And so this observational study showed that patients who received ketamine and had a high shock index exhibited blunted hypertensive responses and more frequent hypotension. And this was thought to be due to ketamine having negative inotropy and vasodilatory properties when used in patients with a higher shock index compared to the patients that had a low shock index. So in this study, it was those where the index was less than 0.9, and they had sustained increases in pulse rate and systolic blood pressure. So seeing that ketamine is increasing your plasma catecholamine concentrations in those patients. And then lastly, 2020, there was quite a large observational study specific to air medical patients, and they found that receipt of ketamine was associated with higher incidence of hypotension and cardiac arrest. And so then lastly, we'll compare some of the literature that we currently have that looks at etomidate and ketamine and the differences in patient outcomes. And so just briefly, starting with a randomized control trial that compared etomidate and ketamine and found no significant difference in mean max SOFA scores. And then a randomized control trial for more recently, 2022, of about 800 patients that found that day 7 survival was significantly lower in the group that received etomidate. However, that day 28 survival, there was no significant difference between the two groups. And then 2023, a meta-analysis of about 2,700 patients, again, found that etomidate increases mortality compared to the other induction agents looked at. So it wasn't just ketamine, but a couple others. And then a study from 2024, again, another meta-analysis of just shy of 3,000 patients that compared ketamine versus other induction agents. And they found that there was a moderate probability that induction with ketamine was associated with a reduced risk of mortality. And then a couple studies from last year, 2025, one being a meta-analysis of just shy of 24,000 patients, found that etomidate was associated with a higher incidence of adrenal insufficiency, and that those receiving ketamine required more post-intubation vasopressor support. However, between those two agents found no difference in 30-day survival. And then lastly, a meta-analysis also out of last year, again, also found no difference in mortality outcomes, but found that ketamine was associated with a higher risk of hypotension. So taking all that background into this study, ketamine or etomidate for tracheal intubation of critically ill adults, the purpose of this study was to determine effects of the use of ketamine as compared with etomidate for induction of anesthesia during RSI. And so this was a pragmatic, multi-center, unblinded, randomized parallel group trial that was across 14 sites, that spanned 6 medical centers in the United States. And so they looked at 6 emergency departments and then also 8 intensive care units. And they collected data from April of 2022 to August of 2025. And the study was conducted by the Pragmatic Critical Care Research Group. And they were able to perform this study in a randomized intent using the exception of informed consent. And so another little piece about the methods and an interesting caveat for how they determine dosing of this agent or these agents for patients that were assigned to the group is that they had these charts that they use. So as we talked about earlier, ketamine is commonly dosed on a range of 1 to 2 milligrams per kilogram. And so making this chart just for ease of administration and trying to reduce any confounding variables is that clinicians could choose the dose they felt was optimal for the patient. And then, although we talk about etomidate is typically dosed at a flat dose of 0.3 mg per kg, they included the chart for etomidate as well, with my interpretation being just to have similarity between the two groups, that you're picking these doses on a range using the chart regardless of what you're assigned to, again, just to minimize confounders. And so being able to pick a dose from somewhere in that chart that was clinician decided. And then as far as our inclusion and exclusion criteria, so they looked at all adult patients who were critically ill and undergoing tracheal intubation with the use of an induction agent. And then they excluded pregnant patients and prisoners and those with a primary diagnosis of trauma. So the parentheses there are the numbers of patients that ended up being excluded in those groups. We don't have a good number for the primary diagnosis of trauma just because they were not screened at all for the trial. So we're not sure how many patients were left out because of that designation. And then also if the treating clinician decided that tracheal intubation was so emergent that they didn't have time to go through the randomization process, they were also excluded. And then lastly, if the treating clinician determined that basically there was a contraindication to using either ketamine or etomidate, they were also excluded from the trial. And so they listed in the supplementary appendix about kind of some of the situations where they deemed that these were contraindicated. And so for Etomidate, the main three was that there were 38 patients that were deemed to be more appropriate to receive Etomidate because they had elevated intracranial pressure because of the historic thought that ketamine increases ICPs, which has pretty much been debunked. And then 18 patients that had hypertensive emergency that they wanted to receive Etomidate, and then 15 patients that had tachycardia that were deemed having ketamine as being contraindicated, so they received Etomidate. And then for the group that they determined ketamine was necessary, it was 47 patients with hypotension. So again, thinking that they would get a little bit of hemodynamic support from ketamine, 7 patients that were actively seizing, and then also 7 patients that had bronchospasm. So utilizing ketamine for some of its other nuances for that patient population. And then moving into our outcomes, so primary outcome being in-hospital death by day 28, secondary outcome, cardiovascular collapse during intubation, and safety looking at systolic blood pressure 24 hours after enrollment, and then also ongoing receipt of vasopressors at 24 hours. They also had quite a few exploratory procedural and clinical outcomes that they looked at. So they dove a lot into like the lowest and highest systolic blood pressure changes, also some information about like ventilator-free days, vasopressor-free days, etc. And then as far as statistical analysis, they calculated a sample size of just over 2,300 patients to detect an absolute difference of 5.2 percentage points. And this was assuming an incidence of in-hospital death by day 28 of 30% in the Etomidate group. And then they also did perform a single interim analysis after about 1,100 patients, just to make sure that they were meeting all the criteria they needed to continue the study, which they did. And then also they ran an intention to treat analysis, and the stats model for the primary outcome was the generalized linear mixed effects model. And as far as the breakdown of enrollment, they had just over 3,400 patients assessed for eligibility, ended up excluding just over 1,000, again, with about half of those because they didn't meet inclusion criteria. And then the other half is that they were eligible, but they were unable to be enrolled either because the trial personnel were unavailable, there was an error that came to the enrollment, or they had a representative decline enrollment. So it left us with just about equal numbers of just a little over 1,100 patients in each group. And then our baseline characteristics were pretty much equally split between both groups in everything that they looked at. So equal age of being an average of 60 years, and then also the ratio of female to male sex was equal. Same with location of intubation between the two groups, same ratios of emergency department and ICU patients. And then you can also see the reasons for intubation were pretty split between the two groups as well. And then also had identical percentages of which paralytic was used for RSI. And then as you can see there at the very bottom, what the average dose ended up being. So remembering that they used that chart to determine what they thought was the most appropriate dose. So the ketamine dose being about 1.6 milligrams per kilogram, so right in the middle of that range, and then Etomidate being 0.28 milligrams per kilogram, so pretty close to our typical 0.3 mg per kg. And then moving into our outcomes. So the first line there being our primary outcome of in-hospital death, they found no statistical significant difference between the two agents. They did find a statistically significant difference of the secondary outcome of cardiovascular collapse. As you can see, it was 22.1% in the ketamine group and 17% in the Etomidate group. And the cardiovascular collapse was a composite measure that was measured from the interval between induction of anesthesia and up to 2 minutes after intubation. And this I'll talk a little bit more about later, but the composite outcome was largely driven by that next line there, receipt of new or increased dose of vasopressors. They did have a swing towards more patients in the ketamine group receiving more vasopressors compared to the Etomidate group. But rates of cardiac arrest were the same, and then ongoing receipt of vasopressors at 24 hours was numerically a little bit higher in the Etomidate group. And then a couple of the hemodynamic measures they looked at. So this is prior to intubation, looking at the receipt of vasopressors, and like prophylactic vasopressor use with induction was pretty split among the two groups. So it just points us to noting that the clinician did not choose to preemptively add vasopressors because they knew they were intubating with a certain agent. These are pretty split between the two groups. And then you can see that they measured the change in systolic blood pressure from induction to the lowest measured systolic blood pressure, and it was a pretty large difference in the ketamine group compared to the etomidate group. And then lastly, what I found pretty interesting that you kind of had to dig in the supplementary appendix for was medications received after intubation to day 28 of hospitalization. And there was a numerically higher difference in percentage of patients in the etomidate group receiving corticosteroids compared to those in the ketamine group. So thinking about how etomidate can cause adrenal insufficiency and how that may affect mortality outcomes. In this study specifically, knowing that the etomidate group did receive a little bit more steroids compared to the ketamine group. And so the conclusions that the authors had for their outcomes is that the use of ketamine for induction did not result in a significantly lower incidence of in-hospital death than etomidate, and that the incidence of cardiovascular complications during intubation appeared to be higher with ketamine than with etomidate. And the author identified strengths and limitations, so strengths being that they were able to perform a randomized control trial and have those balanced baseline characteristics. They had a large sample size to provide sufficient statistical power to detect meaningful differences, and also that they looked at patients in both the emergency departments and the ICUs. And then their identified limitations is that they excluded trauma patients. So as you can imagine, for those of us in the emergency department, this is a large group of patients that we see coming through our doors, and a lot of them we are having to intubate. And then also that technically the study was not blinded, but as we discussed, a lot of the outcomes were pretty objective in looking at measures of blood pressure or, death at day 28. So even though it wasn't blinded to the treating clinician, it may have not actually had a meaningful impact on the outcomes. And of note, the analysis team was blinded to the intervention. And so some of my closing thoughts, I agree that I think it was helpful that the baseline characteristics were well balanced between the two groups. I also like that we have a study that was done in the United States, and it was a multi-center trial spanning both emergency departments and ICUs, so definitely increasing the generalizability. I was a little disappointed that a dose-dependent effect analysis wasn't conducted, especially because we did dose things on these ranges, especially like etomidate, dosing it on a range compared to the fixed dose that we're used to. And so if that using the higher versus lower doses had an impact on outcomes. And then again, like I alluded to during the outcome section, is that cardiovascular collapse was a composite outcome that was largely driven by the receipt of newer increased dose vasopressors. And so although ketamine kind of came up short in this group in, having worsening cardiovascular collapse, it was just this one subsection of that was being driven by. But it does kind of affirm that ketamine can cause hypotension in our patients with an elevated shock index. So it's just a good reminder for all of us to not always expect ketamine to cause hypertension in the patients that we're intubating. Then lastly, kind of the biggest letdown for me of this trial is that it was not designed to look specifically at the impact of adrenal suppression from etomidate in septic patients. So although it maybe showed us that etomidate does not have worsened mortality compared to ketamine, they did not look specifically at septic patients and the effects of adrenal suppression, and kind of provide more details also about the receipt of corticosteroids and how that could have played into that picture. And then as far as continued and ongoing research, there was a study that was actually just published last month as well, looking at ketamine and etomidate in mortality in emergency department intubations. And so this was a cohort study from 18 emergency departments in Brazil. And so they actually found that etomidate may increase the risk of death and that we should evaluate its role in emergency airway management. And so I think we're going to continue to see a lot of studies come out like this, like the one I just presented, and then this one, and potentially still see a lot of pendulum swinging back and forth about whether or not etomidate is going to be harmful for our patients. And then another study that is not yet recruiting, but in the works, that I'm looking forward to is looking at the use of induction medications in RSI specific to trauma patients. So we'll help answer some of those questions that we still had and maybe did not get answered in this study that I just presented. And with that, what questions do you have for me?
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.